Si tiene usted alguna pregunta técnica, por favor, hágalo en el chat a ECOIT o envíelo a la dirección. Esta sesión está siendo grabada y usted tiene que estar de acuerdo con que estemos grabando. Por favor, por la causa de las infecciones, traten de limitar las personas que están escuchando esta sesión. Para interpretación, verán aquí un botón de interpretación. Tenemos 4 idiomas hoy para escoger. Para español, escojan español. Para portugués, portugués. Para francés, la opción de francés. Y para Swahili hay un botón Zoom en la parte de abajo, así que no tenemos Swahili, pongan ahí en donde dice alemán, pronto lo tendremos. Para la sesión de hoy, como verán, tenemos un grupo muy comprensivo de panelistas, estamos muy excitados con esto. La doctora Ana María Crawford de la Universidad de Stanford, Dr. Fatsai Mugasa de la Universidad de Zimbabue, doctora Shelley Porter de la Universidad de Stanford, doctor Alassane Dati Mohamed de Nigeria, y que es hospital de enseñanza también, Eugene Tuyishime de la Universidad de Ruanda, pero entiendo que él está en Toronto, y doctora Jean-Claude Wimana del Hospital de Distrito de Kibogora en Ruanda, Dr. R.J. Ramamurti de Stanford University, Dr. Travis Rees Nguyen de la Universidad de Stanford, Debbie Lester, especialista global de salud, Kiara Stetson, que es de Unidad de Cuidado Intensivo de Stanford, y Eli Sung, de Cursos de Crisis de Stanford. Antes de empezar con Ana Crawford, quisiera brevemente pasárselo a Clark Quigley del proyecto para que diga unas pocas palabras. Eco India, queremos hacer a Clark un co-host para que pueda hablar con nosotros. Muy buenos días o buenas tardes, depende de dónde estén. Gracias por dejarme entrar. Estoy muy contento de unirme a esta sesión. Quiero decirle hola a todo el mundo y quiero darle las gracias por esta nueva asociación con Stanford University también. Veo mi colega aquí, Dr. Rees Nguyen, que es colega mío en ECO, así que le pasaré a Bruce. Tienen también, por favor, que pasarle esto a Bruce para que pueda decir algo. Gracias, Clark, y gracias, Mónica, y el equipo de Stanford, y nuestros colegas en India, quienes nos ayudan en Assist en Stanford para producir estos programas ECO y poder entonces hablar sobre esta pandemia de hace unos meses. Este pasado mes volvimos a juntarnos para coordinar la próxima fase de esta serie de terapia de oxígeno, y vamos a estar asociados y con la asistencia de Stanford y nuestros colegas en India, quienes también nos están ayudando. Así que lo más importante es que apreciamos mucho que tenemos personas de África, del mundo, y gracias por tomar el tiempo para unirse a nosotros. Y gracias. Ana Crawford. Y quisiera comenzar primero compartiendo mi pantalla. Hay varias personas que se han anotado para el Open Access gratis, en el recurso gratis que es en línea. pero para los que no lo han hecho, les voy a mostrar cómo registrarse para el LRC y les voy a dar un tutorial del LRC según vamos progresando. Para cada sesión en esta serie estaremos usando el recurso de educación para mostrarles todo lo que estamos discutiendo en estas series. Así que voy a comenzar ahora a compartir la pantalla. Este es el centro de recursos para aprendizaje. Así que el centro de recursos global tiene muchos recursos. Los primeros 3 estamos desarrollándolo y mucho más relevantes en los problemas de hoy día, hablando de COVID-19. Tenemos los fundamentales de cuidado crítico y también la serie de oxígeno. Así que lo primero que tiene que hacer para entrar al centro de recursos, como ven en la mano derecha, lo que hacen es el sign in. Si esta es su primera vez que usted se registre, tiene que, no ponga su nombre todavía, ponga crear nueva y entonces podrá tener una cuenta gratis y entonces entra su palabra, su nombre y su código. Esta es la primera página cuando uno entra. Y aquí verán nuevamente diferentes cursos. Tenemos 2 páginas de cursos. No todos todavía están completados, pero los primeros 3, estos 3 primeros, ya están llenos de recursos que son gratis, están accesibles y ustedes los pueden acercar. También tenemos una página de comunidad, como verán. Así que en este recurso de educación tenemos más o menos 500 personas, usuarios. Así que si tienen alguna pregunta o desean discutir algún contenido en este Learning Resource, recurso de aprendizaje, lo que pueden hacer aquí es poner su pregunta y entonces se la envía a la comunidad completa y podrá usted recibir serie de oxígeno y esta la hemos desarrollado en el cuidado de pacientes pediátricos y adultos por varias razones, pero primeramente neumonía es la causa más grande de muertes de niños para niños menores de 5. Son infecciones respiratorias y oxígeno es la primera terapia para SARI, para infecciones agudas respiratorias o para síndrome de dificultad respiratoria aguda. Así que cuando ustedes vean la simetría, pulsar, oxímetros y terapias pueden disminuir las muertes de pacientes si se usan apropiadamente. Así que vamos a ver esta primera sección. Vamos a entrar al disclaimer. Antes de escuchar esto de un minuto, quiero mostrarles un poco aquí a la izquierda la columna. Esta es la columna para navegar. Así que ven que estamos aquí primero. Y aquí hay 2 elementos en este primer modelo. Así que pueden repasar el curso para ver los diferentes elementos de aprendizaje. O pueden usar los botones que dicen previo o próximo para moverse. También pueden abrir y cerrar este panel para hacerle clic aquí y para abrirlo le dan a la doble flecha nuevamente. Así que vamos a cerrarlo ahora y vamos a escuchar este video de 1 minuto. Los módulos que van a ver ahora tienen la intención de promover el intercambio de conocimiento y de experiencias. En ninguna forma tienen la intención de sustituir juicios clínicos y ni decisiones independientes de profesionales de salud. Los que están mirando el material son absolutamente responsables de sus propias decisiones. Creadores de estos materiales no tienen ninguna responsabilidad de ningún tipo de pérdidas. Los creadores y administradores tratan de mantener esto al día, actualizado con la última información. Sin embargo, la información cambia rápido. Los creadores y los autores no se toman la responsabilidad con información que no sea correcta. Cada proveedor individualmente es responsable de adaptar la información y hacerla como a esa persona le convenga. Entonces, el próximo elemento. Entonces, el centro de recursos de aprendizaje es un lugar de aprendizaje para todo el mundo, no importa los recursos que tengan ni el entrenamiento. Así que tenemos aquí lo que prometemos, que es que vamos a no tener ningún tipo va a ser acceso abierto, no vamos a tener ningún tipo de... los creadores de esta serie se incluyen yo, y en realidad no tengo ningún negocio, ni tampoco estoy envuelta en ningún negocio, y nuestros Assist International y Project ECHO son nuestros socios. Así que el recurso es para personas que quieren aprender y también para educadores. Si usted es un educador y usted quisiera pasar estos aprendizajes y enseñárselos a otras personas en su facilidad o en su área, tenemos un manual para facilitadores que explicará alguna de la teoría de aprendizaje y también darle instrucciones paso a paso de cómo llevar a estas personas que van a aprender sobre estos materiales que están siempre disponibles y es acceso abierto. Así que es un guía de cómo uno puede accesar esto y cómo llevar las sesiones. Así que vamos a brincar esto ahora. Vamos al aprendizaje. El objetivo de toda esta serie está aquí. Nosotros lo que queremos es que haya discusión en proveedores, en
Please know that when I'm sharing my screen, I cannot see the chat box. So if you have questions, feel free to enter them into the chat box, and the panelists will help answer those questions. So we have, instead of learning objectives, we have what are called practice change objectives, because we feel that being present and learning the materials and being able to take a test does not improve patient outcomes. But if we provide tools and have discussions around unique solutions, especially when resources are limited, that we can actually affect the practice change of providers, hopefully to improve patient outcomes. So the practice change objectives for this series include healthcare providers following recommended PPE guidelines. Healthcare providers are trained in the safe don and doff sequences for PPE. Patients with potentially contagious infections are isolated early. Screening methods for SARS-CoV-2 are in place. Healthcare providers recognize and diagnose hypoxemia, and healthcare providers use pulse oximetry to appropriately triage hypoxic patients. And then the last objective is for healthcare providers to prescribe non-invasive oxygen therapy using the most appropriate device available. So the first part of the case is the chief complaint. We have a 57-year-old man with chills, weakness, and a dry cough. So the first question is, this patient is in the emergency room. How would you evaluate him further? So I'm going to go to the chat box and see. If you have an answer to the question, go ahead and put it in the chat box. So when you have a patient who presents, what's the first thing you do to evaluate the patient? Okay, someone says check SpO2, a good start. Vital signs, okay. What else? What would you want your medical student or nursing student to say? After history and examination. So the first thing that we do is a history and physical exam. Give a mask to the patient. These are all good answers. History and physical, very good, Jean-Claude. Okay, wonderful. So we'll go back to screen share and we'll continue to see what the answer is. There's the chat box, wonderful. Okay, so as you go through the Learning Resource Center, I want you to note that almost everything, you can click on it to get the answer. So in this blue box, it says this patient is in the emergency room. How would you evaluate this patient further? If you click on that box, it will take you to the answer. So here we have a resource, especially for our students, for our nursing students and medical students, is how to take a proper history and physical. So it gives you step-by-step instructions on how to do a history and physical. So the first thing we always do with our patients is an H&P, or history and physical. So we'll close that back since most of you got the correct answer. You decide to perform a history and physical. When interviewing the patient further about the history of his present illness, you discover he has a 4-day history of chills, weakness, and a dry cough. His wife is a nurse at the hospital and tested positive for SARS-CoV-2 3 days ago. His wife has a pulse oximeter at home and had the patient check his oxygen saturation. The reading was 89%. So his wife has sent him to the emergency department. The next question, should you be wearing PPE? Praveen says yes, yes. Most people are saying yes. We have one no. Of course. I like these answers. Wonderful. Everyone wants to wear PPE, which is wonderful. So again, I mentioned that when we have a question, you can click on the box to get the resources that support the answer or the answer. Everyone wants to wear PPE. I love it. Perfect. So again, I'm going to hide the chat box. Again, when you click on the question, it takes you to resources. And so you see we have an outline of personal protective equipment. We have some resources from the CDC, or the Centers for Disease Control, about recommended PPE. We also have information about how to put it on, and we also have information about how to take it off. And then we have information from the World Health Organization on PPE guidance. So let's go through these resources. And remember, we can get rid of this left navigation pane, or this left column, by clicking the double arrow to make it smaller. So we want to wear PPE. Everybody agrees with that. So how do we decide what PPE is necessary? So we can click on this first resource from the CDC, and it says who needs PPE. The patients with confirmed or possible SARS-CoV-2 infection should wear a face mask when being evaluated medically. So one of the first things one of our participants said is put a mask on the patient, which is absolutely correct. Healthcare professionals should adhere to standard and transmission-based precautions when caring for patients with SARS-CoV-2 infection. Recommended PPE is described in the infection control guidance. So let's scroll down. You'll see that there's how to put on PPE, and there's a list of instructions. There's also how to take off PPE and a list of instructions. I think most of you realize that taking off PPE is the most dangerous point in time for possible contamination of the healthcare worker. So you really want to make sure that everyone knows how to put PPE on and everyone knows how to take it off safely. So on the CDC website, you can see lots of really nice PDF infographics. Because these are PDFs, some of them come in different languages. You can print these out and you can display them in your healthcare facility. So let's click on this one. Not only does it show you the preferred PPE, which includes a face shield or goggles, an N95 or higher respirator, a pair of clean gloves, and an isolation gown. It also shows you the acceptable alternative. If you don't have an N95 or higher respirator, you can use a basic surgical face mask. So this is the recommended PPE, but also there's instructions for the safe donning and doffing of PPE. So printing this infographic out and hanging it in patient care areas is one way you can improve the safety of all healthcare providers. When a healthcare provider is taking care of a patient with known or suspected COVID-19, they are oftentimes nervous and they may actually forget a very important step, especially during the donning process. So having these reminders in patient care areas is one way to keep your healthcare providers safe. And also to remind yourself, even if you've put on PPE multiple times, you will oftentimes forget steps. There are other infographics about how to put on your face mask and wear it properly. As you know, oftentimes you will see people wearing their face mask with their nose hanging out or the straps hanging down, or they'll put it on their head, or they'll put it around their neck or their elbow. All of those things are incorrect and increase the chances of contaminating the healthcare provider. So this is another reminder for healthcare providers that if you find it's helpful, you can print it out and also hang it in patient care areas. Okay. There are two videos here that you can use to educate providers. One shows you how to safely put on PPE, and if you scroll to the next one, it's how to take PPE off in a safe manner without contaminating yourself. So using these videos, using these infographics, hanging them in patient care areas are all ways that you can change your practice to increase safety for healthcare providers. Okay, let's go back to the case. So everyone agrees that we should be wearing PPE. Notice next that we have practice change action items. Again, we're steering away from learning objectives, and we want people to be able to feel empowered to change their practice to improve patient outcomes and keep healthcare providers safe. So create training sessions for all providers in the safe donning and doffing sequences. Print PPE infographics and display in relevant patient care areas, and then place PPE checklists on doors of PUI or COVID positive patient rooms. So this is an interactive discussion. Do any of the co-panelists have anything to add about PPE or alternatives to the PPE that's recommended by the CDC, or other questions that have come up during your practice?
Sure, I have a quick comment. So I'm sorry I have like a bias in simulation. So I believe like whenever possible, practice donning and doffing in simulation before you go into clinical practice. So the second point is that if they have a second person to be there, so that they can look on the steps, if the steps are followed, especially during doffing of PPE. Thank you.
Yeah, that's an excellent point. We call that extra person in our setting, we call that person a safety officer. And so that patient's job is exclusively to make sure healthcare providers are donning and doffing in a safe manner. And if they do contaminate themselves, to wash their hands thoroughly. Yeah. Kara, did you have something to add?
I agree. I think we found the safety officer really key, especially for ancillary staff who don't spend a lot of time donning and doffing, such as techs and phlebotomists. The other thing, and this will probably depend on your facility, but if you have the appropriate supply of PPE, we also switch out PPE if we're going to be moving patients through the hospital. Most importantly, the gown and the gloves. If you're moving and touching clean spaces, doorways, elevators within a larger facility, ideally you're switching out your gown and gloves.
So that's a great point too, and maybe it needs to be said explicitly, but when we're talking about specifically SARS-CoV-2 or COVID-19, we're exercising.
Tukiongea hasa kuhusu COVID-19.
Pardon, Maggie?
I'm translating this, I'm interpreting the same term simultaneously.
Oh, is it possible for you to mute? Thank you. So the thing that needs to maybe be said explicitly is for SARS-CoV-2 or COVID-19, we need to exercise contact, droplet, and airborne precautions, so that if you're moving a patient who's possibly infected from one area of the hospital to the other area of the hospital, that anything you touch, you could potentially contaminate. So wiping down surfaces during those workflows is very important as well to avoid contaminating the environment as well as other healthcare providers. Wonderful. Anything else to add about PPE before we move on? Any other learning points? Okay, wonderful. So let's go back to the case. So how would you triage and isolate this patient? You can type in the chat box. How would you triage and isolate this patient? We know that he has a cough. We know that he has chills, and we know that his oxygen saturation is 89%. So how do you decide where this patient goes, and how would you isolate him? We'll give a few seconds for people to type their answer in the chat box. Okay, wonderful. So people are starting to realize that he may need oxygen, he may need to be admitted to the hospital. Great. Okay, so let's click on the box for the answer. It's going to take us back to the CDC, or the Centers for Disease Control website. And this page has a lot of information, but one of the key things is to recognize that screening processes and triage need to be in place for any facility. So someone's mentioning isolation, which is also great. So some places have implemented telehealth, which means that when patients are ill, they can call in to a phone number and speak to a nurse, and the nurse directs the triage protocol. During these strategies, the nurse has a series of questions that he or she will ask the patient, and based on the answers to those questions, it will determine where the patient should go. Some patients with mild illness who are not hypoxemic can be managed at home. Others need to report back to their physician in 24, 48 hours for a check. And yet other patients, such as our patient in this case, need to be admitted to the hospital for oxygen therapy. So these triage protocols are really great, and this website will give you the phone transcript that your nurses can use. And for each answer, it gives you an algorithm of where that patient should go. So if you go through the transcript and you scroll down to the bottom, you'll see an algorithm of the phone call that the nurse can then determine if one answer is given or the next, how the patient should be managed. So you can see here dispositions. They need to go to the emergency department. They can call back in 24 hours. If it's a healthcare provider, they need to go to occupational health. If it's in a retirement home or a long-term care facility, how to manage that, or whether the patient can stay at home and call if they get worse. So this will really help triage patients before they get to the hospital, because once they're at the hospital, if they are infectious, they could potentially infect other people, including healthcare workers. So very important. The other thing this page offers is visual alerts and posters. Again, you can print these out. What the symptoms of COVID-19 or SARS-CoV-2, what those symptoms are, so that if they have those symptoms, they know that they need to socially distance and they need to wear a mask. Okay, so if any of these infographics are helpful, you can print them out from this page and hang them in your healthcare facility. Okay, and the rest of it says physical distancing, and then healthcare providers should be wearing PPE. So some of the other important recommendations is to limit visitors to the facility. So many hospitals now will not allow family or visitors to come see patients because they want to encourage physical distancing. Also, they recommend limiting the entrances to the hospital so that only a few entrances are available, and that those entrances are screening sites. So everybody should be screened before entering the facility for COVID-19. And those that have infectious risk should be turned away unless they're patients being admitted. Okay. So how will you screen this patient for SARS-CoV-2? What are the presenting symptoms of SARS-CoV-2? So go ahead and enter that in the chat box. And I'm going to stop screen sharing for a second and just ask panelists and participants how their facility is triaging patients. How do you screen and triage patients at your facility? Dr. Ramamurthy, I know that you work in the Children's Hospital. How is it that you screen the patients? Do they screen them outside of the hospital? Do they come straight to the emergency room? What happens when they get to the emergency or admission? I think you're on mute, sir. Perfect. Looks good.
Yeah. Well, thanks to your teaching and everything, I think both the children's side and adult side, they pretty much follow the standard way of using the PPEs and donning doffings. Whenever we try to triage patients, I don't think there's any big difference. The one thing that in pediatrics is we have to be conscious about the parents, and we have limited the number of parents. We used to have free, accompaniment of all, both the parents so far, but with the COVID, we are restricting only one parent. I'm sure every place has its own unique, restricting the traffic of the attenders, but here we're only allowing one parent currently. That's the main difference in pediatrics, other than, standard PPE precautions.
Thank you. Fadzai, how do you screen your patients before they come to the hospital?
Well, with us, if a patient is suspected COVID, we've got particular hospitals that they're being directed to. We are encouraging patients to call in for assistance and not to present at the hospital. So if they have a high suspicion that they are COVID positive or they're presenting COVID symptoms, they call a help center that we have, And then usually someone from there will come and attend to them. And then depending on how they're doing clinically, if they need admission, they're then referred to a COVID center. If not, they're then managed from home. And because of resource limitation as well, we've had incidences where a patient requires admission, but unfortunately there are no available beds. So usually we have interim ways to manage them in terms of an oxygen concentrator being provided at home until a bed is available. In the other hospitals, we are screening all patients as they come in outside the hospital. If you come to Zimbabwe now, there's a screening tent or a screening, a certain area has been allocated for screening. The healthcare workers that are there are in full PPE, and they screen everyone as they come in. And like he mentioned with the pediatric hospital, for us, even with the adult hospitals, we are discouraging relatives to come with you. So you either come in by yourself, or if you are unable to, with one person to accompany you. Everyone gets screened at the door and is only allowed in thereafter.
Thank you. So Dr. Fadzai is in the University of Zimbabwe. Jean-Claude, you're in a district hospital in Rwanda. Can you tell us how your hospital is handling triage? Where is Jean-Claude? Maybe he's not on the call anymore, or he is muted.
And I can tell you in Seattle, if Jean-Claude isn't available, we're doing very similar. So for
Thank you. Jean-Claude needs to unmute, but Debbie, yeah, thank you.
we are doing a similar, just screening patients. We originally had tents also set up outside for the pediatric hospitals, and limiting sort of screening, and also within the actual ED department having specialized rooms or areas if we had suspected COVID patients. Also limiting entrances into the hospital and screening, limiting visitors. So one parent but very similar to what we're hearing from all of our colleagues.
Okay, wonderful. Jean-Claude, you should be able to unmute now. Wonderful, thank you.
Okay.
What goes it, John?
Yeah.
Yeah, you go.
Yeah, okay. So in our hospital, we have a screening area at the entrance of the hospital where we took temperature, and for patients that are suspected to be COVID-19, there is an isolation area where we kept them, and we wait for the results, and after the results we can know whether they can still in that area, or they can move to a treatment center, because we have a treatment center nearby, and with that we are able to manage and to deal with COVID-19 patients.
Okay. So it sounds like, so I'm going to go back to the case and screen share again, but it sounds like different facilities have different methods. It sounds like in both Zimbabwe and Rwanda, they have separate treatment centers for COVID patients. That's not always the case. Sometimes it's just a different treatment area within the hospital. So it depends on the facility on how that is managed. Thank you for sharing your perspectives.
Yeah.
Okay, so practice change action items. Establish screening stations, ideally outside of your facility. Identify screening personnel and questions. Use a screening checklist. Screen everyone, which includes both workers and employees, as well as patients and families. Use a telephone appointment and algorithm for triage when possible. Limit the entrance points to the facility. Post visual alerts at entrance points. Triage high risk and symptomatic patients to areas of isolation. Again, this can be within the hospital or it can be a separate treatment center. Provide hand washing supplies and ensure face coverings. This is something, I was actually in Rwanda when COVID broke, and this was something that Rwanda did very quickly and did very well, much better than in the United States, in fact, is that hand washing stations were mandatory before entering any building. So that's a very important part of decreasing the contact spread of COVID-19. And then finally, ensure the waiting areas are well ventilated and seats are 6 feet or 2 meters apart. Okay, let's continue with our case. The patient denies fever, shortness of breath at rest, headaches, loss of taste or smell. He's talking in full sentences, but he states he becomes short of breath when moving and eating. He has been less active and is mostly staying in bed or on the couch. The nurse obtains the first set of vital signs. His heart rate is 95. Blood pressure is 95/52 millimeters of mercury. Respiratory rate is 24 beats per minute. His saturation is 89%. Temperature is 37.5 degrees Celsius. What is hypoxemia? What is hypoxia? And what is the difference? Again, this is a question for the participants. What is hypoxia? What is hypoxemia? And what is the difference? And why is it important? So we can use our chat box. Does anyone know the difference? This is something that is important, but sometimes not taught, even in your ICU rotations and training. I see people are still answering about triage. Those are wonderful answers. Jean-Claude, very good. If you didn't know that, I would be upset because you are my student. Hypoxia is tissue oxygenation. Very good, Lucy. Wonderful. Okay, let's go back. And again, when we're in the Learning Resource Center, I mentioned that if there's a question, you can click on it for the answer. So before we watch this video is 4 minutes long. I want to again show you a little tutorial about the Learning Resource Center. So we're about to watch a video. We probably want to make the screen bigger so we can get rid of this left navigation pane by clicking the double arrows. There is a paperclip icon here in the top right corner. If you click on that paperclip, you can see you can get a transcript for a French interpretation. Apologies, there are no other languages available at this time, but you can click on this document and it will give you French translation into that document. Okay. It seems to be taking, yeah. Okay, so en français. So we'll clear that. So that's for French speakers. We can clear that out. The other things I want to show you on the Learning Resource Center for the video is if the video speaks too quickly, you can hover here and you can speed it up or you can slow it down. You can adjust the volume here and then you can make the transcript bigger or smaller. So this is the transcript. It will go through these words in real time as the video plays. Also, if you want to make it full screen, you can click on this square and it will make it bigger. So let's watch this 4-minute video.
Diagnosing and treating hypoxemia requires providers understand its definition and how to detect hypoxemia using pulse oximetry or arterial blood gas analysis. When we breathe, we pull air into our lungs. Room air contains 21% oxygen. When oxygen enters our lungs, it travels to the alveoli, where it diffuses from the alveoli into the pulmonary capillaries. Oxygen then either binds to hemoglobin within the red blood cells or diffuses into the plasma. This is called oxygenation. Insufficient oxygenation is called hypoxemia. The rate at which oxygen is delivered to the cells and tissues of the body is known as oxygen delivery. Inadequate delivery of oxygen to the cells, tissues, and organs of the body is known as hypoxia.
Okay, so we are only going to watch the first 2 minutes of this video because we found our answers. So the difference between hypoxia and hypoxemia. Hypoxemia is low levels of oxygen in the blood, and hypoxia is low oxygen delivered to the tissues. So there's a difference between what you can detect with a pulse oximeter, which is hypoxemia. You can detect low levels of oxygen in the blood, but it doesn't tell you what the level of oxygen delivery is to the cells and tissues. So oftentimes when we say what the patient is hypoxic, we diagnose that either clinically with arterial blood gases or with pulse oximetry. It tells us the levels of oxygen in the blood are low, but it does not tell us how much oxygen the cells and tissues are seeing. So that's important because definitions of hypoxemia sometimes will vary depending on which reference you use. Okay, so let's go back. And we're going to go to the next element. So again, what is hypoxemia? What is hypoxia? What is the difference? You can click here to watch that video and that discussion. So what are the common causes of hypoxemia in adults and children? Type it in the chat box. What do you think the common causes of hypoxemia are? Obviously, we're talking about COVID a lot these days, so COVID-19 can cause hypoxemia. What else? Okay, septicemia, good. ARDS, wonderful. High spinal, yes. Low oxygen tension, pneumonia, fibrosis, wonderful. VQ mismatch, I love it. Wonderful, wonderful, wonderful. Okay, good. So again, let's click for the answer.
In addition to diagnosing hypoxemia, it is also important for healthcare providers to recognize the common causes of hypoxemia in neonates, children, and adults. Hypoxemia is defined by low levels of oxygen in the blood and is detected using arterial blood gas analysis or pulse oximetry. Pulse oximetry is more widely available, but arterial blood gas analysis is more accurate when available. The exact level of oxygen saturation that defines hypoxemia is not clearly defined, as the level at which tissue hypoxia occurs is not known. However, most clinicians agree that an SpO2 less than 90% by pulse oximetry qualifies as hypoxemia. A hypoxemia diagnosis can be made using arterial blood gas analysis. But if ABGs are not available, a pulse oximetry unit can also be used. In the instance where neither tool is available, bedside providers must use clinical signs to guide administration and titration of oxygen therapies. Common causes of hypoxemia in neonates include, but are not limited to, birth asphyxia, respiratory distress syndrome, pneumonia, sepsis, congenital heart disease, meconium aspiration syndrome, and apnea. Common causes of hypoxemia in children include, but are not limited to, acute lower respiratory infections such as pneumonia or bronchiolitis, asthma, meningitis, sepsis, congenital heart disease, perioperative complications, malaria, and trauma. Finally, common causes of hypoxemia in adults include, but are not limited to, chronic obstructive pulmonary disease, asthma, pneumonia, sepsis, trauma, congestive heart failure, pulmonary embolus, and perioperative complications.
Okay, wonderful. So do any of the panelists want to add anything about the causes of hypoxemia? Anything we missed?
And I was just going to add, just for our clinicians, just for the early newborn period right after birth, that it is common to see those low levels of oxygen. So either by oxygen saturation in a newborn, or if you have the ability to measure the arterial blood gases, and that should be going up, you know, as the baby's, you know, in the minutes and hours after the baby's born, but that can be common. And also when they are cold stressed, it's very hard to pick up an accurate SpO2 saturation reading as well. So there's some other factors that can affect your ability to sort of clinically diagnose, that just sort of keep that in mind.
Wonderful. Thank you for sharing that. Yes, Shelley, Dr. Porter.
No, respiratory therapist Shelley Porter, but I just wanted to add too that we can't forget cardiac issues. I know we've talked about a lot of respiratory issues, but we got to think about cardiac issues as well.
Wonderful. Thank you. Yeah. Dr. Dati, did you have something to add?
Yeah. Yeah, sorry, the other time I wanted to comment, but it was raining heavily here, so I decided not to, but now I can hear well. I want to say that while we practice daily, sometimes we give drugs that tends to, and then you have low readings. So people should not panic, but they should know what they are doing. And then we also, what I see, pulse oximetry is our best option, because the broadcast analysis is not feasible in most centers in low and middle income countries. So we constant limitations of pulse oximetry. For example, a patient in shock or cold extremities, you are bound to get low readings or abnormal readings, so that they will not interpret. So they should link it up with other clinical features at that point. Thank you.
Yeah, wonderful. Thank you for that. Arterial blood gases are not widely available, so using pulse oximetry is really a great way to detect hypoxemia and help you know when your patients need clinical care and oxygen therapy. I will say that even in some of our settings, we don't have enough pulse oximeters. And so recognizing the clinical signs and symptoms of hypoxemia is also very, very important. And those signs and symptoms may look different in adult patients versus pediatric patients. So excellent points. Thank you. Okay, let's continue on. I do want to show you one other thing about hypoxemia. So there's a big picture of lungs here. If you click on the lungs, it will take you to a really nice algorithm that we found about hypoxemia. And it divides the causes of hypoxemia into 4 separate groups. One is that there's not enough oxygen in the alveoli. So there's not enough oxygen coming into the lungs. And that can happen in 2 ways. One is hypoventilation, which is what Dr. Dati was just mentioning, because you can have medications or other problems with breathing that decrease ventilation. And so you can actually have hypoventilation leading to hypoxemia. You can also have low oxygen concentration in the air that is being breathed in. And this happens, for example, at high altitude. The second category is diffusion problems. This happens at the level between the alveolus and the vasculature. So remember, these alveoli are surrounded by pulmonary capillaries. So if for some reason the oxygen can't diffuse across the alveolus into the capillary, then you would have a problem with the diffusion leading to hypoxemia or low oxygen in the blood. Oxygen sometimes cannot bind to hemoglobin, or it binds where it can't release from the hemoglobin, and carbon monoxide is an example of that. And then finally, in category 4, we talk about the VQ, V being ventilation, Q being perfusion, VQ mismatch or shunt. And these are very commonly seen. So VQ mismatch is things such as COPD and asthma or interstitial lung disease. Pulmonary embolus is a common cause of VQ mismatch or dead space. And then shunt is, as Shelley Porter mentioned, you can have cardiac problems leading to shunt, or you'll have hypoxemia. And then you have physiologic shunt that can occur in other places. So if you'd like to read more about this algorithm, again, you can click on this picture here and it will take you to that information. So is this 57-year-old patient hypoxemic? You can type yes or no into the chat box. This is our 57-year-old patient that presented with chills and weakness and a dry cough. Everyone says yes, he is hypoxemic. Wonderful. So when we're talking about COVID-19, there have been some really wonderful tools developed by a few organizations that will help us determine when our patient is hypoxemic, but also what to do about it. So notice I clicked on that question to get the answer. There's an oxygen wall chart that was developed by the WFSA, or the World Federation of Societies of Anesthesia. LifeBox, we'll be hearing a lot about LifeBox tools in the next session, but they have a pulse oximetry triage tool. And then there's a lovely oxygen escalation tool on EMDocs. So these are external websites that will help us manage patients who are hypoxemic for COVID-19. So let's click on the oxygen wall. So this says that you suspect and confirm the diagnosis of COVID-19 infection. You use your pulse oximetry, and if it reads less than 90% in an adult, adolescent, or a child, then you need to start oxygen therapy. And you can start that using nasal cannula or a catheter or a face mask. And then you want to titrate the oxygen to keep the SpO2 greater than 90%. You can see the different oxygen delivery devices in this box. The nasal prongs, you should use 1 to 5 liters. The nasal catheter, this is in children, you can use 1 to 2 liters. Oxygen face mask, 6 to 10 liters per minute. Or the oxygen face mask with the reservoir bag, what we often call a non-rebreather, you can use at 10 to 15 liters per minute. This oxygen wall chart was developed for places that have limited resources. So it actually gives you decontamination, cleaning solutions and recommendations. So these are recommendations from these organizations on how to clean and disinfect your oxygen delivery devices. So let's go back to the LifeBox triage tool next, which is another very helpful tool that we'll go through thoroughly on the next session. Sometimes LifeBox takes a minute for this page to load, but this tool is downloadable. So you can click on this tool and download it as a PDF and print it from your computer. And you can print it in all of these different languages. So whatever language is most useful to you. So again, it tells you how to screen and triage your patients using pulse oximetry. So you can screen the patient for fever. Our patient does not have a fever. For cough, our patient does have a cough and he is short of breath when he moves. He's not short of breath at rest, but when he does activities, he's short of breath. And his respiratory rate, if you remember, was 24, and he's an adult. So all of these screen yes, that he is at risk of having COVID-19. The emergency signs are obstructed or absent breathing, severe respiratory distress, central cyanosis, shock, coma, or convulsions. He does not have emergency signs. But we will follow the yes and go down to this box. Check oxygen saturation with a pulse oximeter. His is 89%. So it's less than 94. So we want to go down to this box. And it tells us we should give supplemental oxygen initiated at 5 liters per minute for adults. And then recheck it. If it stabilizes and raises to over 90%, you can recheck it again in 15 minutes. But if it doesn't go to 90% or greater, it remains less than 90%, you need to increase the oxygen that you're delivering to the patient. So if your oxygen improves, then you can recheck it after several minutes. But if it doesn't improve, you need to continue to escalate oxygen. Okay? What questions do you have about screening with pulse oximetry and escalating oxygen care? You can type this in the chat box. And do the panelists have anything additional to add about pulse oximetry and screening and what levels would determine hypoxemia? Okay, this is a great question. For how long do you continue to give oxygen? Kiara, do you mind just unmuting for your comment?
Sure. I was just going to mention with the escalation of oxygen delivery devices, just a reminder that if you're working with that patient in an ER or within a room with other providers or transporting that patient, just make sure they have a procedure mask, if you have that option at your facility, over an oxygen delivery device, to include a non-rebreather mask. So to just try and contain the contamination as much as possible.
Mm-hmm. Yeah. So Savine asks a really great question, and it's a very common question. It's one of our frequently asked questions, which is for how long do you give oxygen? And this is a really excellent clinical question because we have to deliver oxygen for the patient, but we also need to make sure that our resources are available for all patients that may need oxygen. So we deliver oxygen to keep the patient's SpO2 greater than 90%. Now, Shelley brings up a good point that in COPD, sometimes their oxygen levels are lower, so we may target greater than 88% or 89%. But in most patients, we would like to target an SpO2 greater than 90%. If the patient's SpO2 continues to increase from 90% to 94%, what will we do? We have a patient on 5 liters nasal cannula oxygen and the SpO2 is 94%. Will you continue to give oxygen? Good. So people say, yes, continue to give oxygen, but you can try to turn the liters per minute down. So the goal is greater than 90%. If the patient is at 90%, you cannot titrate down because that's the lowest level that we want to achieve. But if the SpO2 continues to increase, you can start to titrate down your oxygen and see if the patient can maintain that saturation. So it's constantly reevaluating how the patient is doing and what their SpO2 is. So you can see the importance of pulse oximetry in managing oxygen therapy. Great. Any other comments from the panelists?
Yeah, I just want to reemphasize what you just said. Bearing in mind our limited resources, we want to conserve oxygen as much as possible for other patients. We should, it's more that we escalate oxygen therapy. we should monitor frequently so that we can de-escalate. In saturation of 95 or thereabout and it's sustained, you should be documenting room air, this is what you have, and then if it is sustained, then you can now observe the patient and turn to other patients. Because I've seen that practically, continue to give 5 liters when you try to change to 2 liters and see if it's sustainable, you are conserving oxygen and so on. So, and then the other key point, the pulse oximetry you're using to monitor your management or adequacy of whatever input you're making. Choosing the device is very important, because where you have a patient that nasal cannula is not adequate, the patient is mouth breathing and so on, then that will not help you at all. So you're going to be getting a different result. Thank you.
Thank you, Dr. Dati. So when you look at the LifeBox triage tool, it actually says that if the patient is stable, you recheck in 15 minutes, you recheck in 15 minutes, you recheck in 15 minutes. If the patient is unstable, meaning the oxygen saturation is going down or is up and down, so not stable, then you recheck 2 to 5 minutes, every 2 to 5 minutes. So it's very important. It's very important to realize the importance of monitoring, especially if you don't have very many pulse oximeters. You may have to check one patient, then another patient, then come back to the first patient, isn't it? So monitoring is very important, and that monitoring will help you determine whether you need to go up on your oxygen delivery or you can come down on your oxygen delivery. So the LifeBox triage tool can be used at the beginning, but then it can be used again and again every time you want to reassess that patient. Okay, perfect. Should we continue? Hello, Bona. I see you. Okay, so this was our patient. We said, yes, he's hypoxemic. And here are some practice change action items. You can print and download the oxygen wall chart. You can print and download the LifeBox triage tool. So Savine, as you have these questions, you can use that LifeBox triage tool again. So you can print it and put it in your patient care area so that when people have the same question, you can show them on the triage tool how to use the oxygen and pulse oximetry. You can post both of these, the wall chart and the triage tool, in patient care areas, such as the emergency department, the wards, and the ICU if available. And then you want to assign an equipment manager to process all the contaminated reuse items, okay? So if we said this patient is hypoxic, and we click on that, remember we have the oxygen wall chart and we also have the LifeBox triage tool. Notice there's a paper clip again on this page up here. If you click on that paper clip, you can download and print the wall oxygen chart or the LifeBox triage tool. So these things are always available on this website for you. If you want to just show your colleagues the triage tool, or if you want to print it and hang it in the patient care areas, those are ways that you can change your practice to help patients and impact patient outcomes. So those things are always available. You recognize right away that this patient is hypoxic. The SpO2 was less than 90% on room air. While you continue your interview and physical exam, you decide to administer oxygen therapy. You are training a nursing student and he asks, how much oxygen is being delivered to the patient and why did you choose that oxygen delivery device? So this is a frequently asked question by our participants. Which oxygen delivery device do you use? And what flow in liters per minute of oxygen will you start? And once you do that, what fraction of inspired oxygen can be delivered with each oxygen delivery device? So let's click on that for the answer, and you'll see that we come to this page with the oxygen delivery devices, and also it gives you the oxygen concentration for each device. So for nasal prongs or cannula, you can see they can be used in the adult patient or the child. And the flow that should be used with nasal prongs is 1 to 5 or 6 liters per minute. And when doing so, you deliver 28 to 40% FiO2, or fraction of inspired oxygen. So if you scroll down, you can see the nasopharyngeal catheter. Note that this is used in infants and children and can deliver 45 to 60% FiO2 and is limited to 1 to 2 liters per minute. If you keep scrolling, you can see the simple oxygen face mask. Again, 6 to 10 liters per minute, 44% to 60% FiO2. And then for non-invasive oxygen delivery devices, the mask with the reservoir bag can deliver the highest FiO2, so up to 95%, but it does require 10 to 15 liters per minute. So that's a high flow, non-invasive oxygen. And then also some places have Venturi masks. Not everyone has a Venturi mask available, but it uses these separate valves that are different colors. And depending on which valve you use will determine the FiO2 delivered. So again, I mentioned that many things on the Learning Resource Center can be clicked on to get further information. You can click on this and it will take you to a resource that goes through oxygen therapy systems. And it will tell you each of these devices, how to put it on the patient, and what the FiO2 is, okay? So if you want further information, you can click on that box for nasal prongs. There's one other thing I wanna show you for children's, for pediatric patients. If you click on this nasopharyngeal box, it will take you to some really great resources about oxygen therapy for children. And this is organized by the World Health Organization. So this is a very long resource, and you can see the table of contents. It talks about many different things for oxygen in children. We'll have a separate session about pediatric patients later in the series. Great. So which oxygen delivery device? So this is a 57-year-old patient and his SpO2 is 89%. So what oxygen delivery device will you choose? You can type it into the chat box. Which oxygen delivery device will you choose? And this is for your setting. So what is available to you in your setting? We have some people that have nasal prongs available. So Sabine and Sushil, what liters per minute will you use? What delivery device and how many liters per minute? Many people have nasal prongs, it appears, which is good. Wonderful. Okay, so nasal prongs, and you would use 5 liters per minute according to the LifeBox triage tool, which is great. So we're having answers anywhere from 2 liters per minute to 5 liters per minute on nasal prongs, which is wonderful. So if you start your oxygen at 2 liters per minute and the oxygen saturation does not improve, what will you do? The SpO2 is still 89%. What will you do? You can increase to 5 liters. You can switch to a simple mask. Wonderful. Let's say you switch to a simple mask at 6 liters per minute and the patient's SpO2 is now 90%. When will you recheck the SpO2? Some people say 5 minutes, some people say 15 minutes. I think if you can tell that you check again in 2 to 5 minutes and the patient is stable, then you can check again in 15 minutes. But you want to make sure that your initial intervention stabilizes the patient. So the first thing to make sure is that your patient becomes stable, meaning they can maintain that SpO2. Okay, once the patient is stable, then you can go to 15 minutes. You can decrease the frequency of checks to 15 minutes. Good. Wonderful answers. Thank you for participating. Anything else to add from the panelists?
I just want to stress a point I think that was made earlier. For us, we made it mandatory for all our patients, once, whether on face mask, to always have a surgical mask on them, just to limit contamination to the working staff and other patients in the unit. I think that's something that's really important and needs to come out for everyone to understand.
100%, could not agree more.
Resource permitting, yeah.
So if we don't have enough surgical face masks, we could also just use the face coverings, isn't it? Yeah, and the importance when you don't have enough surgical face masks and you just use, for example, a homemade face covering, it's important that it has at least 2 to 3 layers, and that will actually improve the safety of that garment. So 2 to 3 layers face mask. So if a patient is wearing a nasal cannula, they should be wearing a face mask, right? A face covering. What about a simple mask, an oxygen face mask? Shelley, would you? Yeah. Sorry, Fadze. Shelley, would you still put a face mask on the simple mask?
Yes, absolutely. Can you guys hear me okay?
Yes, thank you.
Okay,
Yeah.
good. Yes, it's really important to use face mask covering on any device that the patient is, well, not any device, because some devices, when the patient's in the room by themselves, it's okay. But when you enter the patient's room, it's important to cover their face, or when they're being transported throughout the hospital, it's important to cover their face. But yes, any device, basically, it's okay to cover the patient's face with a face mask.
Yeah, and in some places we don't have individual patient rooms. So especially if the patients are around other patients, or healthcare providers are only separated from the patient by, for example, a curtain. All of those patients, when you add oxygen flow to the patient, it has the potential for the virus to aerosol. Okay, it has potential for the virus to contaminate the surrounding air and environment. So it's important to cover that patient's face to help contain the aerosol. And that's to protect other patients, but more importantly, the healthcare providers that are directly at the bedside. So with a nasal cannula, with a simple mask, and even with a mask that has the reservoir bag, we can put facial coverings over all of those devices. Great. Okay, let's continue with the case. Okay, so you tell your nursing student that you are going to use the nasal prongs and that you're going to use 5 liters per minute. We have very limited equipment. Are there guidelines for reusing disposable equipment? Do you have guidelines at your facility for reusing disposable equipment? You can type it in the chat box. Yes, Cliff has some guidelines for reusing disposable equipment, which is great. Anyone else have reuse? Okay. I bet if we click on this, we will find some guidelines for reusing equipment, right? Everything is clickable on the Learning Resource Center for you to have good resources. There is a book on decontamination and reprocessing medical devices for healthcare facilities. Again, this is published by the World Health Organization. And so if you go through the table of contents, you can find lots of information about how to decontaminate medical equipment. Additionally, if you remember So this is, if you click on the question, if you remember the oxygen chart, the wall oxygen chart also had recommendations for cleaning and reusing single-use equipment. Okay, this nursing student is very inquisitive. He asks, where does the oxygen come from? And do we have enough for all the patients? So we will discuss that in another session. But I want to review with you the practice change objectives that we set at the beginning of this session, that we want all healthcare providers to follow recommended PPE guidelines. We want all healthcare providers to be trained in the proper don and doff sequences for PPE. We want to isolate our patients that are potentially contagious, develop screening methods for SARS-CoV-2, recognize and diagnose hypoxemia, use pulse oximetry for triage, and prescribe oxygen therapy using the most appropriate device. So the topics that we discussed today was infection prevention and control, PPE, screening, triage, hypoxemia, pulse oximetry, oxygen therapy devices, and disinfecting single-use equipment. And I want to end this session with a nice quote from a colleague from Nigeria who says, don't do the easy thing, do the right thing. And I think those are very wise words because it may not be easy to develop all of these protocols, especially if they're not in place. But as healthcare providers, you are all champions for your patients. So it's good for you to recognize what needs to be done versus what is being done now and bridge those gaps. Change your practice to save patient lives. So, panelists, any things to add or any further questions? Because we're coming at the end of the 90-minute session.
Anna, I just wanted to add, just with the decontamination of single-use pieces of equipment, one thing I have seen, just as a little tip, when you're not achieving the results that you want with a nasal cannula, is sometimes the internal piece of the prongs can become corroded on the inside. So for some organizations that or hospitals that don't have an abundance of nasal cannula and do need to reuse, it's just a good thing to just double check the integrity of the actual, because it's very hard to see. And we learned that a lot of patients, it was also burning out oxygen concentrators because they were kind of, the pressure was trying to get through these sort of obstructed cannula. So just a little tip for some of our practitioners out there.
Wonderful. Thank you so much, Deb. So this session was all about triage. The next session will be more about using pulse oximetry and managing oxygen therapy for hypoxic patients. One common question we get from participants is to get the slides. Can we have the slides so that we can teach other people? We want to equip you to be champions for your networks and to be teachers for your networks. We would love for you to cascade this learning to anybody who could benefit. We don't have slides, but we do have the Learning Resource Center. So we encourage everyone to sign up for an account. All of that information is there for you as an educator and as a learner. So you can go into the Learning Resource Center anytime. It works on a computer, it works on a tablet, it works on a phone. So you can be on rounds with your students going through the LRC on your phone. It will work on iOS or Android devices. So the Learning Resource Center is for you as either a learner or as an instructor. So feel free to use it anytime, any way that you think it will benefit others. Any more questions? Thank you all so much for participating. Yes, Dr. Dati. Dr. Dati is my from Nigeria.
Yeah, I just want to add on the use of the simple surgical mask. There's a proper way to wear it. I understand one part is the filter. Then one part is light colored, and like this one I'm holding, the light part where there's a filter. So you put it on the patient, so you don't want the patient to aerosolize. So you get the best protection. Because if you wear it this way, you are virtually doing nothing. The mask, the light part is the light colored part is the filter, where the filter is. So it prevents the patient from aerosolizing to the environment. So as you put the mask. So I just want people to remember this. Thank you.
Yeah, Dr. Dati, that reminds me of another point, that when we wear simple surgical face masks, or when we wear our face coverings that we make at home, those masks are protecting others. They're not necessarily to protect us. So those masks are very important, and it's a sign of respect to others that you want to protect them. So wearing a mask is protecting other people. So it's very important to protect your community. And so even when the patients come into the hospital, that's why we put the mask on the patient, is to protect the rest of the people in the hospital. So it's important that you wear your mask correctly. It's important that you cover your nose and your mouth. Masks and social distancing really make a big, big difference. You know, Shelley Porter and Kiara just came back from a Native American reservation here in the United States. And for those of you who don't know, the Native American reservations are very different from the rest of the United States. They don't have the same resources that many other places have. But the thing that they learned is that this reservation, because it instituted sound, scientifically proven public health policies, such as isolating, social distancing, and masking, that even though around the reservation, many, many people have COVID, the incidence of COVID on the reservation itself is very, very, very low. So washing your hands, social distancing, wearing masks, those things work, and they protect healthcare providers, and they protect the community, and they protect patients. It's very important. It's probably wearing masks, social distancing, and oxygen are probably the most important components of beating COVID.
Thank you. Thank you, Anna Crawford, and all of our panelists today. We just have 1 or 2 minutes of final housekeeping. I do want to be cognizant of everyone's time. We're just over the 90-minute session. I know there were a lot of questions that came in registration. If we didn't answer them, we will. We want to continue this conversation. We have had a WhatsApp group. As you'll see, there's a link to the QR code there. We're going to continue that, and we're also going to continue or to move forward with discussion forums and more learning on the Learning Resource Center. So please sign up for that, and we're going to continue this conversation. Our sessions will be held monthly, same time, the end of every month on that Monday, same time. And we will send out session invitations early, so you'll know. But please, please, please keep continuing the conversation throughout the month. In order to obtain a certificate of attendance, you will need to fill out a short survey. My colleague Alana has put a link to the English and the French and Swahili versions currently in the chat box. Please take a look. And we will share the Spanish and Portuguese versions very shortly by email. My colleague Alana is now going to update and include a short Zoom poll right now. If you could please fill it out before you leave the session, that would be wonderful. If you could just fill it out as I finish speaking, that would be great. Again, all presentation slides or the LRC and recordings, the links will be available on our website at assistinternational.org, as well as through Stanford Global Anesthesia in all the different languages. Again, please sign up for our WhatsApp group. And if you have any questions, please email us at echo@assistinternational.org. I would like to thank Project ECHO. I would like to thank all of our fantastic panelists today and Stanford Global Anesthesia, in particular, Dr. Anna Crawford, for leading this session and creating the Learning Resource Center. As well, I'd like to thank GE Foundation for making this possible, along with Project ECHO. Again, we will be continuing this throughout the year, so please join us. Keep joining, keep practicing safe physical distancing, wearing masks, washing your hands. We're going to leave up the Zoom poll for a few minutes. If you could please fill it out. And yes, again, if you have any comments that aren't included in our questions, Cliff, as you mentioned, in terms of interpretation, please write them in the Zoom comments. We're going to look through everything and make changes to our next session to accommodate. So thank you again very much. And we've now concluded this session.